mouse.
You should be good now.
Yeah. There we go. Okay, so we're gonna do just a little terminology here because one of the biggest problems that we have in the vascular anomalies clinic is that people come to us with all these diagnoses, and so I'm going to try to give you what we, those of us in the vascular anomalies clinic, consider the appropriate terminology. So cystic hygroma, lymphangiomas, lymphangiomatoses are passé. We don't refer to the patients in that way anymore. There's an International Society for the Study of Vascular Anomalies, and this is truly an international society. Most of the people really are from Europe. Anyway, but this is kind of the body that we all pay attention to the classifications. They have a new classification that just came out this 2015. And for lymphatic malformations, they classify them as microcystic, macrocystic, or mixed. So no matter where they are, those are the way they classify them. So the microcystic are the patients who the lymphatic malformations are too small to be aspirated under ultrasound guidance. So they don't put a specific size, but I will tell you that when we're dealing with these patients with interventional radiology, if the individual cysts are less than a centimeter, then they say they're too small to treat that way. If they're larger than that, they're macrocystic, and of course mixed, it's part microcystic and part macrocystic. So the reason that's important is that the microcystic lesions are poorly responsive to current sclerotherapy agents, whereas the macrocystic lesions have an excellent response to sclerotherapy. So we're going to talk a little bit more about sclerotherapy in a little bit, but regardless of the location of the lymphatic malformation, and they do occur anywhere, the classification that's important is microcystic or macrocystic, because that's the ones that we can treat successfully without a surgical procedure. Okay, so this is the paper that most people quote or refer to when we talk about patients who have identified macrocystic lesions of the neck, macrocystic lymphatic malformations. So in this paper, and you see that it was written in 1983, so it's old, there were 15 fetuses. 13 of the 15 lesions were larger than the fetal head. All of these, you see 13 out of 15 of the fetuses were hydropic on ultrasound exam. You see that Turner syndrome was in 10 of the patients, and one they did not have genetic information on. But based on the size of these lesions, there were 10 terminations based on the diagnosis. And 3 of the 5 fetuses that were not terminated died in utero, and the other 2 died within a month. So basically, they said this is a lethal anomaly. So they took a very, very narrow view or a very narrow group of patients. And unfortunately, what's happened is people have tended to extrapolate from this group of patients to patients who have big lymphatic malformations. And that's really a major problem, because it is true that you can have large lymphatic malformations of the neck, but it does not mean that they all have a poor prognosis. So again, these were lesions that were primarily posterior. They were very large. Some of them extended all the way down the back of these fetuses. And if you take the babies who don't have chromosomal abnormalities and don't have these very large bilateral cervical lymphatic malformations, the prognosis for our babies with lymphatic malformations is very good. So again, this is a paper that's more than 30 years old and has been used as an example of why these babies are going to have a lot of trouble if they survive the pregnancy. But in point of fact, as we'll go through, that's really not the case in most of the babies that we see. So one of the things that's also noted in this study from 1983 is that most of the babies who have these large posterior cervical lymphatic malformations, they're diagnosed in the first trimester of pregnancy, whereas the lymphatic malformations that we see that have a better prognosis are diagnosed later. So there is a group of these babies, though, that do not have Turner syndrome, don't have chromosomal abnormalities, that do have obstruction of their upper airway. And this term, CHAOS, congenital high airway obstruction syndrome, was coined by the people in San Francisco. And those of you who know the people in the Fetal Center in San Francisco, they love acronyms. They just love to put all these things together. So, this is a special group of babies who have a macrocystic lymphatic malformation or microcystic of the anterior neck. So this is not the group that we were just talking about. Because of the high mortality due to inability to secure the airway at birth, delivery is done by C-section with the head and the upper chest delivered and the airway secured via endotracheal tube or tracheostomy. And this technique is called exit procedure, the ex utero interpartum treatment. So this is just a diagram of what's done. Now, probably one of the most important things about this, people who aren't aware of this technique, is the mother has to be in extremely deep general anesthesia because you do not want this baby moving. So the baby and the mother have to be under deep general anesthesia. This technique, you see the baby's head and upper chest is delivered, but they keep the fetal circulation going. Then they maintain the airway, they establish an airway. And this can be done not just for the babies who have lymphatic malformations, but it's also done if they have significant masses in and around the neck. Teratomas can occur, and they can be treated the same way. And you have about somewhere between 30 and 45 minutes to accomplish whatever you're going to do to establish the airway. So this is what these babies look like. Now, for those of you who haven't ever seen this procedure, these babies are blue. They look dead, okay? Because the PaO2 of a fetus is around 45. So it's not a normal-looking baby with their head sticking out of the uterus. And it's pretty impressive. So what they do is they monitor the babies. They put pulse oximeters on them. They monitor their heart rate. But again, these babies are not moving. They're not breathing, and you don't want them breathing. Because once they start to breathe, then obviously they're going to shut off the fetal circulation. But this is what the babies look like when they do this procedure. Okay, so in the babies who do not need the exit procedure, the vast majority of our prenatally diagnosed lymphatic malformations of the head or neck do not warrant this special delivery preparation. Unless the lesions are large enough to cause dystocia, these babies do not need a C-section. So this is really the bulk of the babies that certainly I see prenatally, and we tell that to the mothers. If the lymphatic malformation appears to impair the airway on prenatal studies, then what you need to be sure, if you're not going to do the exit procedure, you have somebody very experienced in neonatal endotracheal intubation, or somebody that can do a tracheostomy if needed. Again, this is a rarity. I don't know how many exit procedures we've done here. Do you know how many exit procedures we've done? Three? Three and
none of them were for lymphatic repair.
Right.
One was for, two were for oral lesions, and one was for
So, you see, it's a rarity. It gets a lot of press, but in practicality, we don't see very many.
We did have one. That's right, one from Kansas as well.
Okay, so the size of the lymphatic malformation may decrease significantly from the initial diagnosis to birth. So we see this actually a little more commonly in the lesions of the chest wall and the axilla. We've seen this on several occasions where they look pretty impressive when the fetuses are between the 25th and the 30th week, And then as the monitoring goes along, they become less and less impressive. This is, again, particularly of the chest wall lesions. So when I see these mothers prenatally, I always tell them, depending on what it looks like, that's what determines how we treat the baby. The patients who may require something actually done prenatally are the patients who have lymphatic malformations with a significant pleural effusion. If they have evidence that it's causing enough pulmonary compression, then those are the babies who would benefit from a fetal pleural to amniotic fluid shunt. But again, this isn't something we see a whole lot. We do see these lesions in the chest, but generally they don't cause enough shift to be concerned like we see with the CPAP. So there is no currently known benefit to treating the mother with propranolol or steroids for lymphatic malformations prenatally. There may be something that we can do in the future, but for right now, there's nothing we can do to change their outcome.
The pleural effusions there, are those like chylothorax, or is that
yes.
because of that? Okay.
Yes.
That's not because of cardiac.
Right. So it's chylothorax, and you have to remember, because the babies aren't eating anything, of course, the fetuses aren't eating anything, the pleural fluid is clear. So it's a chylothorax because it comes from the chylous lymphatic system, but it's clear fluid. And we know it's chylous, even if they're born and we don't feed them, we know it's chylous, because if you aspirate the fluid, it's about 90% lymphocytes. That's how we know it's chylous. But yes, it's chylous fluid. Chylous, the word really means looking like chyle, looking like milk, but it's chylous fluid. So once the babies are born, for the macrocystic lesions, most of the macrocystic lesions are located inferior to the mylohyoid muscle. So they're in the lower part of the neck anteriorly. The microcystic lesions tend to be higher. They tend to be up into the floor of the mouth, which is the ones that tend to cause more problems with the airway and are the ones that are more likely to require the exit procedure. And they can be pretty impressive in size. So how do we manage these babies when they're born? Well, sclerotherapy has become the frontline treatment for these large symptomatic lymphatic malformations. And the agent that we prefer to use, and when I say we, I mean the interventional radiologist, primarily Dr. Yadav, who does these procedures. The agent that has the most favor is doxycycline, which is a tetracycline antibiotic. The only known complication of using the doxycycline, these babies aren't tetracycline sensitive yet, of course, but is that it can cause some yellowing of the teeth and even yellowing of the bones, just like all tetracyclines can. Now, the way that they do this is they will aspirate the fluid, determine how much fluid is in this macrocystic lesion. And when we see these lesions on ultrasound or MR or CT, they look like they're a bunch of different cysts, but frequently those cysts communicate. So what Dr. Yadav generally does is he'll aspirate the largest cyst, and frequently the entire cystic thing will collapse significantly. Then, depending upon the amount of fluid that is aspirated out of this, he'll inject doxycycline, and again, the concentration depends on the volume you're going to use. And he lets it sit for about 30 to 45 minutes, then he aspirates all the doxycycline. So technically, you would think, well, you probably won't get much of a blood level of the doxycycline. But actually, there was a study done from Children's Hospital of Philadelphia, and they measured doxycycline levels in these babies, and they're substantial. So even though you've aspirated the doxycycline, they do get a pretty good dose. Now, I personally have never seen a child with yellow teeth who was treated with doxycycline, but that's what we always tell the parents. So it doesn't have a lot of other serious complications. Another agent that's been used in these, particularly the head and neck lesions, is bleomycin. which most of you know is a chemotherapeutic agent, and it's the same kind of thing. You inject, and this agent does have some, if you get a lot of it, does have some serious complications, including pulmonary fibrosis. But again, they don't leave it in there, and you're not repeatedly generally treating these kids with it. So the bleomycin has had some success in the microcystic lesions, but when the parents say, what's the likelihood that this treatment is going to work, the likelihood that the treatment is going to work, if it's a macrocystic lesion, is about 85 to 90%. If it's a microcystic lesion, it's about 20 to 25%. Depending on the size and the location, many of these patients need more than one treatment. The treatment is always done under general anesthesia. It's painful. And for that reason, we delay the time that we treat these babies. We generally don't do the treatments until the kids are several months of age, around 6 months of age. We can do it at any time. So in the babies who have a very large macrocystic lesion of the neck, and it's causing them some airway difficulties, you can do it when they're a couple days old, a couple weeks old. Dr. Yadav did a patient about 3 or 4 years ago. It was a 1.6 kilogram premature infant who had a large cystic lesion in the chest, and actually the neonatologist called me and said, we think this kid needs to go on ECMO because we're having so much trouble ventilating the baby. I said, 1.6 kilos, you know, that's below what we normally would put on ECMO. And I went over the films with Dr. Yadav, and he said, well, never done anything like this in a baby this size, but why not? And because, you know, going on ECMO was not a very good option. And he aspirated the fluid, injected doxycycline, aspirated it. The kid was extubated in 2 days and went home, and they were 2 kilograms, never had recurrence. So it's pretty impressive how this works, and the reason, the way that the doxycycline works is it damages the lining of the lymphatic malformation so that when they're collapsed, the fluid doesn't recur. So for those of us who operated on these lesions, you say, well, why don't you just take it out? Well, the lymphatic malformation it does not respect tissue planes. So it kind of goes in between all the important structures, and you can imagine in the neck, it's, you know, into the carotid sheath and around the nerves and down into the muscle. So you never really get rid of all of it when you operate. And when we're doing operations regularly on these, the recurrence rate exceeds 50% in these big lesions. So you subject them to a big operation, you may cause significant morbidity, and the success rate is actually higher in the ones that are macrocystic if you can do sclerotherapy than it is in the ones that you operate on. So yes, we do operate on some of these, but we select them because if we can get them to be a little bigger, we can start the sclerotherapy. Obviously, we prefer to have babies who are a little bit further out from the newborn period to subject them to general anesthesia, and that's why we tend to wait till they're a little bit older. But we can do them at any age. It's just that if they're not all that bothered by it, we wait till they're a little older.
What about in fetuses? Anyone try to do this?
No. No. I'm not aware of anybody who's tried sclerotherapy in the fetus.
I don't know what the advantage would be.
I mean, if you had a very big lesion that you were, you know, going to be faced with an exit procedure or something like that, would you do a third trimester?
Yes, yes. We have no way to do that.
Could be the general mom.
Yeah.
But that's putting 2 people.
And you'd have to really, really general mom in order to take a medicine. I would imagine.
I mean, I guess the only thing to do is just aspirate it and then deliver it.
Yeah, I think I know people have aspirated them, but I can tell you, if you aspirate it and don't do sclerotherapy, they're going to recur very quickly. So you've done a procedure, unless you're going to deliver the baby very rapidly, I would guess within a few days it would recur pretty quickly. So why do they have these lesions? People ask me that frequently. You know, the lymphatic system is just carrying tissue fluid back to the heart, and for some reason, either the number of lymphatic channels are decreased or they're absent. There's some blockage. We don't understand what really triggers them, but once they develop, we know that generally they're going to continue to be a problem. When the babies are born, usually these things are floppy, they're soft, they're not causing the kid any problem, they're not having any trouble eating. But we always tell the parents that they may acutely get larger and they may acutely get tender. And that's generally due to either cellulitis, which actually is less common, or spontaneous bleed into them. So frequently we'll see them in the vascular anomalies clinic, and they'll be a month old or 6 weeks old, and we'll say, you know, we're going to watch this. Don't freak out about it. We'll continue to follow you, and then when you're about 6 months of age, if it's still a significant cosmetic issue, then we'll treat it with sclerotherapy. And then a week later, they'll call and say it's twice the size, and it's tender. So then we do an ultrasound, and on ultrasound, you can tell when they've bled into it because the lymphatic malformations they're dark. It's a clear fluid. There's nothing in them. But when they bleed into them, they'll get some debris in them. And frequently, when the patient lies down, you can see the debris in a dependent position, similar to what we see in the ovarian cysts. When they have torsion, you'll get a fluid level, and that's when we know that they have bled into them. And sometimes, if it's a fresh bleed, they'll kind of look like those little crystal balls with snowflakes in it. You'll see the particles floating around in them, and it's just blood that's floating. And under those circumstances, if there's no sign of infection, frequently we don't treat them. If they're painful, then we do the sclerotherapy earlier. Just aspirate fluid and do the sclerotherapy earlier. So if they were a couple months of age, we'd say, okay, you're symptomatic, now we'll treat you. The cellulitis is interesting because if they get a cellulitis in a macrocystic lesion, it will often damage the wall of the lymphatic malformation, and it actually may make it go away. Not that we want them to be infected, but sometimes it's a form of autosclerotherapy, if you will. Some of these lymphatic malformations do get smaller over time, but they don't go away. They never really go away. So when they get smaller over time, we always tell the parents, that's great, you know, they're asymptomatic, we're not going to treat them, but you need to know they may come back. And we frequently will see patients in the vascular anomalies clinic who are 4 years of age, 7 years of age, 15 years of age, and they'll come in with this swelling in their neck, and they'll say, well, I've never seen anything like this before, and it's a lymphatic malformation that's been there forever. It's just something triggered it, and particularly when the kids get ear infections or any type of infection of their head and neck area, it'll swell acutely, and this is a common phenomenon. So we've taken a conservative approach to the smaller lesions, and I'm not going to define in centimeters the smaller lesions. It kind of depends where they are and how they are, because people have reported regression of these lesions, and so we always ask the parents to take a picture of the lesion so that we have a way that we can follow them, keep it on their phone. Yes, we take pictures in the lymphatic malformation in our vascular anomalies clinic, but we want the parents to have it as well so that we have a way we can follow them. But yes, there are some of these things that truly do go away. I would say maybe 20, 25%, not a big percentage. I mentioned about the infection causing reduction in size. The agent that Dr. Nancy Ballman of the Vascular Anomalies Clinic has used extensively in the past is an agent called OK432, which is a derivative of streptococcus. So when you treat babies with this, they get what looks like an acute infection with cellulitis. It's red, it's tender, it's hot. The OK432 is not any more effective than the doxycycline, and we've pretty much given up using the agent, but it is an agent that's been used in the past. So what about if they're microcystic and you can't treat them with the sclerotherapy, or sclerotherapy is ineffective? Well, unfortunately, there's no medicine that's been proven effective in treating LMs, although people have tried propranolol, just like we use it for hemangiomas. We don't really know why it works. There are some reports of propranolol improving the LMs. Remember, some of the LMs go away on their own, so it's always hard to tell if you just have 1 or 2 patients. There's an ongoing trial of using sirolimus, which is an agent used in transplants. So it's a profound immunosuppressive medications for large microcystic LMs. We have a couple of patients who've been treated with this and have had a very good result. We've also had some patients who've had no response to it. But it's a prospective study. It's multi-center. It's based in Cincinnati by a lady named Denise Adams. But as I say, there are 5 centers. So I'm hoping we'll have some information from them soon. So surgery is always an option. As I already mentioned, it has a pretty high recurrence rate. There's actually a technique that we've used a couple times now when we have to operate on kids with lymphatic malformations, in which we put a vacuum dressing, a sponge, on the lesion. We don't actually close the skin, and suction the fluid that's left in there. So we excise what we can, we suction out what we can't, and then usually for 10 days, 2 weeks, depends on the location and what's going on. And then we bring them back to the operating room after we've changed the suction dressing a couple of times and then formally close the wound. And that seems to have decreased the recurrence rate, which is always very distressing for the parents and the surgeon to do this big operation and they have a recurrence in a couple of months. You feel pretty bad. Okay, so to kind of summarize what we've talked about today, prenatally diagnosed lymphatic malformations generally have a good prognosis, notwithstanding that article from 1983, although some may require unique treatment such as the exit procedure. The LMs are best treated by a multidisciplinary group and expertise in medical, surgical, and interventional radiology. And I think that in the near future, and by that I mean the next 10 years, I think we'll know a lot more about treating some of these very difficult lesions medically. But we still have a lot to learn about the optimal management of these babies that are diagnosed prenatally. Questions?
Excellent.
Thank you so much. Do you see any of these infants that present as adults or is recurred as an adult?
Yes. So yes, we do see patients who present as adults. We had a lady come to the vascular anomalies clinic. She's 43, and about every 7 to 10 years, she'll have a flare-up of this lymphatic malformation of her neck. And she'd been treated with surgery twice. She'd been treated with sclerotherapy once, and she was interested in being treated again with sclerotherapy. So, again, you don't ever take all of these out. The fact that some of them never come back, I mean, to me, it's a miracle, because when you get in there and you operate on these and you see them, and you know you're not taking out all of it. You take out as much as you can take out, but there are these little tendrils, these little arms of this stuff going in between all these structures, and you think, well, I'm not going to take that out. We've tried to do things like take out as much as we can when we have to operate, and then put doxycycline in, and then put a suction drain on. So it's kind of like belt and suspenders and another pair of suspenders, but they still recur. They still have recurrence no matter what we do. So we never tell them you're cured. The really, really troublesome ones are the ones that are in locations in which they get these lymphatic vesicles kind of percolate up to the skin, and you know, if they have a big surface area, you know, one patient I'm thinking of specifically, there's still tissue, have a big surface area. It's most of his chest wall on the right side. He's a teenager. He's had surgery a couple times. He's had lymphatic, he's had attempts at sclerotherapy, but it's microcystic. So we took out a big chunk of his skin, literally with plastic surgery, this big, all the way down to the muscle, and then put a big suction drain on it, and he's still developing these little vesicles. And so there's some data that suggests, and they weep. Now, he's not having any pain, he's not having any infection, but they weep. And, you know, he's 16 years old. So there's some new laser treatments that may affect those, and our goal is to burn them so that they're a scar instead of being kind of the top of this percolating of this malformation. But yes, this is a kid who's always going to have some problems with this area. He's near adulthood. Fortunately, he's a great kid. He's got great parents, so you know they're pretty tolerant of all of this. But some of them, you know, one operation or one sclerotherapy, they're done. That's great. That's a home run. But it's pretty complicated.
Bill, I'm just trying to understand the basic mechanism better. So you implied earlier on that this may be an imbalance between the amount of extracellular fluid and the volume of the lymphatics. Is it that, or is it an intrinsic wall of lymphatics problem? Because you'd think that if it was a volume discrepancy, that taking the lesion out would just put you back where you started, and that you'd again be facing a situation with decreased intralymphatic volume relative to the volume just meant to drain.
Right. So, you know, that's a great question. And if you think about it, when you treat these patients with sirolimus, you're treating them like it's a proliferative lesion.
Mm-hmm.
But, you know, they kind of stabilize. And so it's a lot different than, say, our hemangiomas, which really act more like tumors, except that they go away spontaneously. Something triggers them to go away spontaneously. So I don't know that anybody really knows the answer to that. There's a lady working with a young doctor working with Laura Tosi in our kids who have lymphatic malformations and significant limb overgrowth. There's a couple of syndromes, Claude syndrome and Proteus syndrome, which they have these different abnormalities, and they're trying to answer that question, trying to get a better idea. They're actually doing biopsies now and trying to figure out whether this is more proliferative lesion or whether it's a mechanical obstruction.
But the histology of the lymphatic wall is normal?
Well, yes. I mean, it looks like an enlarged lymphatic.
I see.
There's no mitoses. There's no, and they don't get bigger. In other words, they don't grow like a tumor grows, but they just don't get smaller on their own, most often. Although, as I say, some do. That means the fluid's got to go somewhere.
Mm-hmm.
So somehow they get alternate channels that drain these.
But the basement membrane's not affected.
Not that I'm aware of, no. I don't know what
Instead of a orderly highway network where you have smaller channels leading to larger channels, you have lakes and pools. And then I think that then the fluid mechanics aren't normal through there. So then when you get upper respiratory infections or something like that, then the fluid doesn't move through it and they can swell. But I don't think they proliferate.
Right. To my knowledge, they don't proliferate. It's just that you never get rid of them completely. So whatever the trigger is, and the analogy I use to parents is, you know, it's a little river, but if you put a dam in the river, you know, you're going to have lakes behind it, and that's the fact that the sclerotherapy works is pretty amazing to me, because you think, you know, that really should work. It ought to, whatever the obstruction is, you're further obstructing it. It should just recur, but it works.
I really think about the first trimester or early second trimester lymphangioma as a different beast. I call those cystic hygromas just to try to separate the two. I mean, we don't treat Turners or down to the hepatocyte cystic hygromas after they're born. They've either resolved or they died. So these lymphangiomas that we see that are focal in the axilla or the neck, I think of as differently, though they are lymphatic. They behave somewhat differently. Have you ever had to treat Turners?
No. No, I've never had to treat. And again, it's hard we're trying to get people to call them lymphatic malformations. And I know why you're doing that, because it signifies a dismal prognosis. But that's what the International Society is trying to get away from, because then it confuses people. And if you call them a lymphangioma, it's a tumor. It's not a noma. It's a lymphatic malformation. And it gets more complicated as we do the other vascular malformations, because that's the same thing they're always trying to do, is try to get people to call them the same thing so we can make sense out of the literature. And when people say, oh, we have this new cure for a lymphangioma, well, then you have to go and see what they're really talking about. And that's, I know it's picky, but that's, they make a big deal out of that.
Are these painful? Like in a newborn who comes out with this, are they in pain?
No, generally not. And again, it's no. And if they are painful, it's usually because they've bled into them. And that's really more common than them getting infected in that first 6 months when we're watching them or trying to determine whether they're going to go away or waiting for them to get bigger so we can do general anesthesia on them. And, we don't know we say 6 months, but as many of you probably know, this whole business about general anesthesia in children less than a year of age, causing maybe some long-term mental abnormalities. We get that all the time now, so we're doing an elective procedure. We'd like to do it as far from birth as possible, but we don't know if 6 months is different than 3 months, is different than 1 year. We just know that there's increasing data that if you have your druthers, you'd rather not be put under general anesthesia as a baby.
And is anyone using OK for too?
Rarely. Nancy has used it in the past, but I can't remember the last patient that we treated.
And
like that.
detergent, I know Bill Shields has been using.
I don't know. I mean, Bhupender Yadav has kind of got his finger on the pulse of that. The doxycycline is what we use the vast majority. As I say, the bleomycin has some success in the microcystic.
And when you're talking about the chaos, many times chaos is due to like a laryngeal membrane or cleft. So is this a lymphangioma that causes compression on the trachea? So okay.
But you have to remember, if you can't get the kids' heads back to intubate them either.
And you
they can't
get access.
Yeah, they can't get access to it. So that's why you have to have people in the exit procedure. You have to have people who can do a tracheostomy to get surgical airway. Sometimes they can't get an airway from above.
Well, thank you so much for coming. It was really
welcome.
fabulous. I don't know if there's any people who have questions. We're unmuted. If you have any questions, you can ask us at this time. But great.
So yeah, I purposely put the references in this. So if you want to have any of these references, all you have to do is just ask for the talk. It's only 16 or 17 slides, but the references in there. We don't have much evidence-based medicine in pediatric surgery. So this is about as close as we get, case series, but it's kind of where we are with it right now.
Great. Thank you so much.
Okay, sure. Welcome.
Thanks. Thank you very much.